Welcome to the Hospital Finance Podcast, your go-to source for information and insights that can help you protect and enhance revenue at your hospital. And now, the host of the Hospital Finance Podcast, Michael Passanante.
Hi, this is Mike Passanante, and welcome back to the Hospital Finance Podcast. Today, I'm joined by Dr. Ambarish Pandey, the lead author of a study published in the July 2017 issue of JAMA Cardiology entitled Association of U.S. Centers for Medicare and Medicaid Services, Hospital 30-Day Risk Standardized Readmission Metric with Care Quality and Outcomes After Acute Myocardial Infarction. And Dr. Pandey has joined us on the podcast today to talk about the results of that study. Dr. Pandey is currently a fellow at the University of Texas Southwestern Medical Center. Dr. Pandey, welcome to the Hospital Finance Podcast.
Thanks a lot for having me over, and thanks for your interest in our work.
So let's start out. First, can you briefly explain for listeners who may not be familiar with it what the Hospital Readmissions Reduction Program is, and then why you and your colleagues chose to initiate this study?
Yeah, that's a great study point. So the Hospital Readmissions Reduction Program is a program that was launched by the Center for Medicare and Medicaid Services, or the CMS, as a part of the Obamacare or the Affordable Care Act. And under this program, hospitals are ranked based on their readmission rates, mostly 30-day readmission rates, and they're compared within the pool of all U.S. hospitals. And centers who have higher than expected 30-day readmission rates for common conditions such as heart attack, heart failure, and pneumonia are penalized a certain proportion of their Medicare reimbursement as an incentive to drive down the readmission rates. And this was started in, the first cycle was, I think, implemented in 2012, and it was based on the 3-year 30-day readmission rate from the previous 3 years of the first cycle. And over time, the amount of penalty has gone up. It started with 1% of the readmission, 1% of the Medicare reimbursement was charged as a penalty, and now it's, I think, as high as 3 to 4%. And the number of conditions that are covered under the Hospital Readmission Reduction Program, initially there were only 3 conditions, and now there are like 6 or more than that. So overall, it has grown quite a bit in the past few years.
And what were you and your colleagues specifically looking at when you initiated the study?
Yeah, so basically what we were interested in looking at was whether or not the quality metric that the Hospital Readmission Reduction Program uses, which is a risk-adjusted 30-day readmission rate, whether this is associated with long-term clinical outcomes and also with the quality of care that the patients get during their index hospitalization. Basically, there's not much data to suggest that 30-day readmission is actually clinically meaningful or is actually associated with the quality of care the hospitals provide. So we wanted to test that if the hospital is being held accountable for a metric, whether or not it matters for the patients in the long term, and it is modifiable by the care that the hospitals provide during the index hospitalization.
And can you, just to get us started with the study, can you briefly go over your methods and data sources?
Yeah, so we used Action Get With The Guidelines NCDR registry data. So NCDR is is a U.S.-based registry of voluntary participating hospitals that provide the data on patients that get admitted for myocardial infarction, and they provide data regarding their quality of care, what treatment they got, their presenting characteristics. And Action is a part of the NCDR and is basically designed to improve quality of care for myocardial infarction in these hospitals. The data set that we used within the Action was CMS link data so that we could get 1-year follow-up results, 1-year follow-up outcomes on patients who are admitted with myocardial infarction during the time period of the first cycle of HARP, or the Hospital Readmission Reductions Program, in an effort to capture how patients did over 1 year based on whether or not the hospitals were penalized.
And we'll dig into some details as we go here, but at a high level, what were the results of the study?
So yeah, basically the main results that we observed in our study were that, number one, we saw a significant difference in the patient demographic profile and the severity of the myocardial infarction presentation at centers who did versus who did not get penalized, such that centers who had higher 30-day readmission rates and were more likely to get penalized had sicker patients and had more commonly African-American patients, in contrast to centers who had a lower 30-day readmission rate and did not get penalized. We also observed that there was no difference in the care quality metrics that American College of Cardiology and American Heart Association endorse for centers with higher versus lower 30-day readmission rates. And also, finally, we saw that the 30-day readmission rates, risk-adjusted 30-day readmission rates, were not associated with one-year mortality and also readmissions after the first 30 days within the first year, suggesting that even though centers are penalized for supposedly performing bad on the 30-day readmission metric, they were not really different in terms of one-year outcomes or in terms of the care quality they provided. So those were the main findings that we saw.
And in the discussion at the end of the study, there was a suggestion that CMS readmissions penalties are perhaps not being equitably applied to hospitals with a prevalence of socially or medically complex patients. Can you explain why that may be?
Yeah, that was one of the key findings that we wanted to highlight. And basically what we saw was that centers that treat more African Americans and more sicker patients were getting penalized despite providing comparable care as well as having comparable clinical outcomes at 1 year, which suggests that even if a hospital provides comparable care to a second hospital, just based on the demographics of the patients they treat and the medical complexity of the disease burden they see, they are more likely to get penalty. And I think this is an important finding, and it highlights that the CMS metric that is being used currently to incentivize a reduction in readmission rates may not be equitably penalizing the hospitals and centers which treat like the disproportionate share index hospitals, which treat more lower socioeconomic strata patients and more sicker patients, may be getting a brunt of the penalty. And they also have lower resources, so this becomes a vicious cycle where centers that treat sicker patients have lower resources at disposal and are getting penalized more, and then thus they have less amount of resource available after the penalties to further improve their care quality.
And it seems from the study that readmissions associated with MI, all-cause readmissions, or mortality were most closely linked with events occurring within the first 30 days of discharge. What does this finding tell us?
So basically what we saw was that for mortality, 30-day readmission was not associated with mortality at 1 year at all. For readmissions, we saw that 30-day readmissions were associated with readmission rates within 1 year, but it was all driven by the admissions that happened within the first 30 days. So basically, if you landmark and look beyond the first 30 days, the penalty status or how a hospital performs within the first 30 days does not tell you anything about how it will perform in the long term after the first month. And thus, it is not a sensitive or a specific metric to comment on how a hospital outcomes are in the long run and whether a hospital does a good job or a bad job in the long run.
Dr. Pandey, could you discuss the potential implications of your study on health policy?
Yeah, that's a great question, and I think the main healthcare implication or the health policy implication that we think our study has is that it highlights the inequitable distribution of the 30-day readmission penalties, such that centers that may be treating more socioeconomically disadvantaged patients and sicker patients are being penalized more despite providing comparable quality of care and having comparable long-term outcomes. So we believe that the readmission incentive policy or 30-day readmission reduction program needs to be re-evaluated and tweaked around to account for the differences in the socioeconomic status of the patients treated at different hospitals, and also to account in a better way for the disease severity of patients presenting to the hospital, so that we can actually bridge this gap and reduce the social inequity in the distribution of the penalties.
Dr. Pandey, thank you for your contribution of this study to the discussion. I'm sure it will have implications as CMS continues to look at these programs going forward. And thank you for joining the Hospital Finance Podcast today.
Thanks a lot for having me and your interest in our study. Thank you.
If you enjoy the Hospital Finance Podcast, please head up to iTunes to subscribe and leave us a positive review.
This concludes today's episode of the Hospital Finance Podcast. For show notes and additional resources to help you protect and enhance revenue at your hospital, visit Bessler.com/podcasts. The Hospital Finance Podcast is a production of Bessler Consulting.